Cerebrovascular Accident, CVA. Introduction. Cerebrovascular accident, CVA, commonly known as a stroke, occurs when the blood supply to a part of the brain is interrupted or reduced, leading to brain cell damage or death. It is a medical emergency that requires prompt intervention to minimize complications such as paralysis, speech impairment, and cognitive deficits. Understanding its causes, risk factors, symptoms, and treatment options is crucial for effective management and prevention. Definitions. According to the World Health Organization, WHO, stroke is a clinical syndrome characterized by rapidly developing signs of focal or global disturbance of cerebral function, lasting more than 24 hours or leading to death, with no apparent cause other than that of vascular origin. According to the American Heart Association, a stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is either blocked by a clot or bursts, causing brain cells to die. Risk factors. Modifiable risk factors: hypertension, high blood pressure, diabetes mellitus, hyperlipidemia, high cholesterol, smoking and alcohol abuse, obesity and physical inactivity, atrial fibrillation and other cardiac disorders, uncontrolled stress. Non-modifiable risk factors: age, higher risk in individuals over 55 years old. Gender, males have a higher risk than females. Family history of stroke. Race, higher incidence in African, Hispanic, and Asian populations. Etiology. CVA is classified based on its underlying cause. Ischemic stroke occurs when a blood clot, thrombus, or embolism blocks or narrows a brain artery, reducing blood flow and oxygen supply, leading to brain cell damage. Hemorrhagic stroke happens due to the rupture of a weakened blood vessel, example aneurysm, arteriovenous malformation, causing bleeding into or around the brain, increasing pressure and damaging brain tissue. Transient ischemic attack, TIA, a temporary blockage of blood flow to the brain, often resolving within 24 hours without permanent damage, but serving as a warning sign for future strokes. Types of CVA. Thrombotic stroke occurs when a blood clot, thrombus, forms within an artery supplying the brain, usually due to atherosclerosis, leading to a gradual blockage and reduced blood flow. Embolic stroke happens when a clot or debris forms in another part of the body, example heart, carotid arteries, and travels to the brain, suddenly blocking a blood vessel and causing a stroke. Intracerebral hemorrhage, a type of hemorrhagic stroke where bleeding occurs directly into the brain tissue, often due to hypertension or trauma, causing brain cell damage and increased pressure. Subarachnoid hemorrhage, a severe condition where bleeding occurs in the space between the brain and the thin protective layers, subarachnoid space, usually due to an aneurysm rupture, leading to sudden severe headache and neurological complications. Pathophysiology. Ischemic stroke, due to thrombosis or embolism. Arterial occlusion, atherosclerotic plaque rupture or embolus blocks cerebral blood flow. Down arrow. Reduced cerebral perfusion, decreased oxygen and glucose supply to brain tissue. Down arrow. Cellular hypoxia and energy failure, ATP depletion leads to failure of ion pumps, causing cellular swelling. Down arrow. Excitotoxicity and oxidative stress, glutamate accumulation leads to calcium influx, free radical damage, and neuronal injury. Down arrow. Cytotoxic and vasogenic edema, brain swelling increases intracranial pressure, further reducing blood flow. Down arrow. Ischemic core and penumbra formation, core undergoes irreversible infarction, penumbra may be salvaged with timely intervention. Down arrow. Neurological deficits, hemiparesis, speech impairment, altered consciousness, vision loss. Down arrow. Complications, brain herniation, permanent disability, or death if untreated. Hemorrhagic stroke, due to ruptured blood vessel. Down arrow. Sudden vessel rupture, Aneurysm rupture or hypertensive damage causes bleeding in the brain. Down arrow. Hematoma formation, accumulation of blood increases intracranial pressure and compresses brain structures. Down arrow. Reduced cerebral perfusion, nearby brain tissue suffers ischemia due to pressure effects. Down arrow. Inflammatory response and edema, release of cytokines and breakdown of blood products worsen swelling. Down arrow. Neuronal dysfunction and tissue damage, compression and ischemia lead to loss of brain function. Down arrow. Neurological symptoms, severe headache, vomiting, seizures, sudden loss of consciousness, hemiplegia. Down arrow. Complications, brainstem compression, hydrocephalus, coma, or death. Clinical manifestations. Sudden numbness or weakness, especially on one side of the body. Facial drooping. Slurred speech or difficulty understanding speech, aphasia. Vision disturbances, blurred, double vision, or blindness. Loss of balance or coordination. Severe headache, especially in hemorrhagic stroke. Confusion and altered mental status. Diagnostic evaluation. 1. History taking. The healthcare provider gathers information about the patient's risk factors, such as hypertension, diabetes, smoking, or previous strokes. The onset and progression of symptoms, example sudden weakness, slurred speech, facial drooping, help determine whether the stroke is ischemic or hemorrhagic. Identifying time of symptom onset is crucial for deciding treatment options like thrombolytic therapy, which must be given within a certain time window for ischemic stroke. 2. Physical examination. A neurological assessment is conducted to evaluate the patient's brain function, muscle strength, speech, coordination, and reflexes. The NIH Stroke Scale, NIS, is a standardized tool used to assess stroke severity by scoring factors like level of consciousness, limb movement, speech ability, and visual fields. A higher score indicates more severe impairment. 3. Imaging studies. CT scan, computed tomography. Purpose, quickly determines if the stroke is ischemic, blockage, or hemorrhagic, bleeding. Why important? If hemorrhagic, thrombolytics, clot-busting drugs, are contraindicated, as they could worsen bleeding. MRI, magnetic resonance imaging. Purpose, more sensitive than CT for detecting early ischemic stroke changes, especially within the first few hours. Why important? Helps identify areas of the brain that are still at risk but potentially salvageable with treatment. 4. Blood tests. Clotting tests, checks for blood clotting disorders that might increase stroke risk. Lipid profile, evaluates cholesterol levels, which contribute to atherosclerosis and ischemic stroke. Glucose levels, high or low blood sugar can mimic stroke symptoms and may influence treatment decisions. 5. Electrocardiogram, ECG. Purpose, detects atrial fibrillation, AFib, or other cardiac abnormalities that may have caused an embolic, clot-related, stroke. Why important? AFib increases the risk of blood clot formation in the heart, which can travel to the brain and cause a stroke. 6. Carotid Doppler ultrasound. Purpose, uses ultrasound waves to assess blockages or narrowing in the carotid arteries, which supply blood to the brain. Why important? Significant blockages can indicate a need for procedures like carotid endarterectomy or stenting to prevent future strokes. 7. Cerebral angiography. Purpose, uses contrast dye and X-rays to provide detailed images of blood flow in the brain's arteries. Why important? Helps identify aneurysms, arteriovenous malformations, AVMs, or large artery occlusions, which may require surgical intervention. Medical management. 1. Ischemic stroke, caused by a blood clot. The goal is to restore blood flow to the brain and prevent further clot formation. Thrombolytic therapy, alteplase/TPA. What it does, dissolves the blood clot blocking an artery. When it's given, within 3 to 4.5 hours of symptom onset, sooner is better. Why important? Can significantly improve recovery if administered on time. Antiplatelet agents, aspirin, clopidogrel. What they do, prevent platelets from sticking together to form new clots. When used, if TPA is not an option or after TPA treatment to prevent future strokes. Anticoagulants, heparin, warfarin. What they do, thin the blood to prevent clot growth or new clot formation. Used in embolic stroke, caused by clots from the heart, often due to atrial fibrillation. Why important? Helps prevent recurrent strokes in high-risk patients. Blood pressure management. Why? High BP can worsen stroke severity or lead to brain swelling. How? Medications like ACE inhibitors, beta blockers, or calcium channel blockers may be used. 2. Hemorrhagic stroke, caused by bleeding in the brain. The goal is to stop the bleeding, prevent further brain damage, and control symptoms. Blood pressure control. Why? High BP can cause continued bleeding or worsen brain swelling. How? Medications like labetalol, nicardipine, or hydralazine are used to lower BP safely. Surgery, craniotomy, aneurysm clipping, or coiling. Craniotomy, opens the skull to remove a hematoma, blood clot. Aneurysm clipping, a metal clip is placed at the base of a ruptured aneurysm to stop bleeding. Coiling, endovascular embolization. A catheter places tiny coils inside the aneurysm to prevent further bleeding. Intracranial pressure, ICP, monitoring and management. Why? Excessive brain swelling can cause life-threatening pressure. How? Mannitol, osmotic diuretic, reduces swelling. Elevating the head of the bed improves blood flow. Surgical drainage may be needed in extreme cases. Surgical management. Some strokes require surgical intervention, especially if they are severe or life-threatening. Carotid endarterectomy. What it does, removes plaque buildup in the carotid arteries, major arteries supplying blood to the brain. Who needs it? Patients with severe artery narrowing, stenosis, 70%, reducing stroke risk. Mechanical thrombectomy. What it does, a catheter is inserted into the brain's blood vessels to physically remove a clot. When used. For large artery occlusions within 6 to 24 hours of stroke onset. Hematoma evacuation. What it does, surgically removes a large blood clot pressing on the brain. Why important? Prevents brain herniation, neurological damage, and death in severe hemorrhagic strokes. Dietary management. Low sodium diet to manage hypertension. High fiber and low fat diet to prevent atherosclerosis. Increased intake of omega-3 fatty acids for cardiovascular health. Hydration to maintain optimal blood viscosity. Nursing management. 1. Impaired physical mobility related to neuromuscular dysfunction and weakness. Interventions. White heavy check mark encourage active and passive range of motion, ROM, exercises to prevent muscle atrophy. White heavy check mark assist with positioning and frequent turning to prevent pressure ulcers. White heavy check mark provide mobility aids, walker, cane, wheelchair, as needed. White heavy check mark collaborate with physical and occupational therapists for rehabilitation. White heavy check mark encourage gradual mobilization while monitoring for dizziness or falls. 2. Risk for aspiration related to impaired swallowing, dysphagia. Interventions. White heavy check mark assess swallowing ability using a bedside swallow test before giving oral intake. White heavy check mark keep the patient in a high Fowler's position, 90 degrees, during meals and for 30 minutes after eating. White heavy check mark provide a soft or thickened diet based on speech therapy recommendations. White heavy check mark educate the patient on safe swallowing techniques, example small bites, chin tuck method. White heavy check mark have suction equipment available to clear airway in case of aspiration. 3. Impaired verbal communication related to damage in speech centers, aphasia/dysarthria. Interventions. White heavy check mark use simple words and short sentences while speaking slowly and clearly. White heavy check mark encourage nonverbal communication, writing, picture boards, gestures. White heavy check mark allow the patient extra time to respond and avoid rushing them. White heavy check mark work closely with a speech therapist to develop communication strategies. White heavy check mark encourage family participation in communication training. 4. Risk for ineffective cerebral tissue perfusion related to decreased blood flow to the brain. Interventions. White heavy check mark monitor neurological status, Glasgow Coma Scale, pupil response, NIH stroke scale, regularly. White heavy check mark keep the head of the bed at 30 degrees to reduce intracranial pressure, ICP, and promote circulation. White heavy check mark monitor blood pressure and oxygen saturation closely. White heavy check mark administer prescribed antiplatelet, anticoagulants, or thrombolytic therapy as appropriate. White heavy check mark watch for signs of worsening stroke, example sudden loss of consciousness, increased weakness. 5. Self-care deficit related to motor and cognitive impairments. Interventions. White heavy check mark encourage independence in self-care by providing adaptive equipment, example one-handed utensils, dressing aids. White heavy check mark assist with feeding, dressing, bathing, and toileting as needed while promoting self-sufficiency. White heavy check mark use step-by-step instructions to help the patient relearn daily activities. White heavy check mark collaborate with occupational therapy for ADL, activities of daily living, training. White heavy check mark provide positive reinforcement to encourage progress. 6. Risk for depression related to sudden disability and loss of independence. Interventions. White heavy check mark provide emotional support and active listening to the patient's concerns. White heavy check mark encourage family involvement to promote a sense of belonging. White heavy check mark offer psychological counseling or support group referrals if needed. White heavy check mark monitor for signs of depression, withdrawal, sadness, changes in sleep or appetite. White heavy check mark encourage participation in rehabilitation and social activities to improve motivation. Prevention. Lifestyle modifications, regular exercise, smoking cessation, and weight control. Blood pressure management, regular monitoring and adherence to medications. Diabetes control, maintaining normal blood glucose levels. Cholesterol management, diet modifications and statin therapy if required. Antiplatelet therapy, for high-risk individuals to prevent clot formation. Stroke awareness, recognizing warning signs using fast, face drooping, arm weakness, speech difficulty, time to call emergency services. Complications. Permanent neurological deficits, paralysis, aphasia, memory loss. Recurrent strokes. Deep vein thrombosis, DVT, and pulmonary embolism, PE. Depression and emotional disturbances. Aspiration pneumonia due to swallowing difficulties. Increased risk of falls and fractures. Conclusion. Cerebrovascular accident, CVA, is a leading cause of disability and mortality worldwide. Early recognition, rapid medical intervention, and rehabilitation are essential for improving patient outcomes. Preventive measures such as lifestyle modifications, blood pressure control, and stroke awareness play a crucial role in reducing the incidence and severity of strokes. Multidisciplinary care, including medical, nursing, and rehabilitative support, ensures optimal recovery and enhances the quality of life for stroke survivors.